Okay. So our brief for today is to look at ACS, whether we treat only the target lesion or look for a complete revascularization. There's been a great deal of discussion on this topic over the last few weeks, and I'm glad I can see lots of teachers and seniors, Dr. KD, who's done a lot of work in this particular field. It'll be a pleasure to interact with him and see what we've got. So this is a story of a 35-year-old male who came to us with an inferior wall MI, and this is what his RC was like. You can see that the mid-RC, this is after he'd been given a lot of anticoagulants and antiplatelets in the emergency. So although he still had ST elevation, the RC was definitely the culprit lesion, but this is what his left circulation was like, with the proximal LAD showing an intermediate stenosis and the proximal circumflex showing an intermediate stenosis, with some disease in the OM coming off in the distal OM as well. The second case, 76-year-old diabetic hypertensive dyslipidemic with recent inferior wall MI, RWMA RCA, but normal LV function, elevated CKMB and troponin. This is what his RCA was like. And again, we see the left coronary artery showing intermediate stenosis in both the proximal LAD as well as the proximal circumflex. Multivessel disease in STEMI is associated with poorer long-term prognosis. Earlier recommendations said only culprit vessel revascularization. Newer trials suggest better outcomes with multivessel PCI. But even across the world, there isn't a consensus on what to do. The American recommendation being selected patient revascularization, and the European recommendation being routine revascularization prior to hospital discharge. This is seen in about 50% of patients who present to us with a STEMI. The culprit lesion in the ACS is often clear. There's a clear recommendation to treat the culprit lesion. The non-culprit lesion wasn't so straightforward except over the last decade and a half. Questions remain as to the modality of assessment, the timing of assessment, the timing of the PCI or intervention if the patient is a candidate. Can physiology help? These are all the questions that we're going to try to answer over the next 10 minutes. Assessment can be angiographic, physiology, imaging, functional, astrology, many techniques. The timing of assessment and the timing of PCI. Now, how do we normally assess the non-culprit lesion? We look at angiography, physiology, imaging-based and assisted, coronary angiogram-derived fluid dynamics, non-invasive CT-based techniques, or at a later date, functional assessment with stress echo and nuclear medicine based. These have all been established and they have place in therapy in various parts. We're going to look at physiology particularly. There are some issues with physiology in the acute situation. There's a potential mechanism for increased non-culprit coronary artery resting flow in patients who present to us with STEMI, and mechanisms for decreased ability to produce coronary hyperemia in the non-culprit vessel, essentially because of increased local vasoconstrictors, a blurred hyperemic response to the kind of agents that we use to produce hyperemia, microvascular compression and edema by remote edema, and increased LVEDP that increases the transmural pressure. Now, we do know that these are all the options available. What is available as far as assessment of the non-culprit lesion is concerned? Angiographic assessment that has advantages of being immediately available. There's no need for a pressure wire software processing. But there's a mismatch with functional assessment. So there is an issue as to whether we actually need to do it or not. And this often leads to overestimation of the non-culprit lesion, even allowing for the oculostenotic reflex. CFR, which is a very attractive concept, but does it distinguish between epicardial and microvascular disease? And it might overestimate the non-culprit lesion severity in the acute setting, and thus has limited clinical use because it varies so much with heart rate, blood pressure, and so many other physiological parameters which are not always well controlled. Fractional FFR, which has the advantage that it is recommended to guide revascularization in stable patients and has a mountain of data to support its use in patients with stable angina. But it may underestimate non-culprit lesion severity in the acute setting, and there remain questions about its ability to prognosticate in the long term. IFR, which has the advantage that hyperemia is not there, but it may overestimate the non-culprit lesion severity in the acute setting, and we may end up doing more where it may not really be required. Testing PDPA with the same kind of caveats as the IFR, and the QFR, which is a newer technique of computational fluid dynamics, but there's a problem because there's a mismatch with the functional non-culprit lesion assessment. Now, I've just chosen this study because of the simplicity, and it also illustrates one of the problems. They looked at 100 patients with acute MIs and looked at FFR of the non-culprit lesions and repeated the same measurements after a mean of 35 days. 14 patients IMR was measured as well. The values were not statistically significant, but even this one small study, when one looks a little more closely, 2 patients who were less than 0.8 at index, were greater than 0.8 at index, were then less than 0.75 at follow-up. with absolutely no difference in the two groups in the corrected TIMI frame count, the percentage stenosis, MLA, IMR. And 10% of the lesions actually crossed clinical cutoff values and thus made it a little difficult to interpret. This means nearly in 10% of patients, we really don't know whether the FFR is reproducible or not in this tightly controlled study. Now, thus, physiology obviously changes from the acute setting to the subacute setting to the stable setting. And in what way does it change? The CFR continuously increases, but as I said, this is subject to so many other variables that it's a little difficult to interpret if we don't know exactly in which part of the natural history the patient comes to us. The FFR has a tendency to underestimate the lesion, becoming significant in the stable setting when it might have been insignificant in the acute setting because of the problems with hyperemia that we discussed. And the IFR actually overestimates and thus might turn out to be significant when in a stable patient, it might be with a similar situation as the same patient, it might not actually be significant. Now, if we look at multi-vessel culprit only revascularization versus multi-vessel revascularization with complete revascularization, there have been 10 trials in this meta-analysis of 7,030 patients. There was actually no difference in the two groups between all-cause mortality, but there was a lower risk for reinfarction, cardiovascular mortality, and repeat revascularization. Not much difference being there in contrast nephropathy and major bleeding amongst these two groups. But if you look a little more inside within this meta-analysis, multi-vessel PCI definitely appears safe for complete revascularization following a STEMI. Non-culprit lesion, when addressed correctly, decreases revascularization. One large trial did show some mortality benefit, but the meta-analysis only shows benefit with respect to revascularization. Can we make a little more precise decisions based on physiology? The studies that used FFR for evaluation of non-culprit lesion only with angiography were PRAMI and culprit, and FFR guided were Dynamic 3 primality and compare acute, and some of the patients in complete. Now, all of them showed across the board that there was an improvement in patients who underwent complete revascularization compared with the control group, which had no further PCI, ranging from 23 to 9% in PRAMI, and Dynamic 3 FFR was 22 to 13%, compare acute was 20.5 and 7.8, and complete was 7.8 versus 8.9%. Well, we do know that it is safe to defer a PCI in stable angina, but what about acute coronary syndromes? This is not exactly STEMI, but in a large meta-analysis, it appeared that deferring a patient based on an FFR in the acute coronary syndrome was almost as good as the benefit size of benefit was quite significant as compared to the stable angina patients in both groups. Thus, deferring a patient seemed to be fairly safe or an acceptable strategy in patients with PCI, with ACS in the non-culprit lesion. What about the natural history of FFR of non-culprit lesions? It does seem to predict long-term events. In this another large meta-analysis, the FFR of less than 0.8 untreated actually had the largest number of events and the lowest event-free survival. So obviously physiology does have some role. FFR plus angiogram, 31% of Dynamic 3 primality actually did not need PCI as compared to the angiography, and 44% of compare acute did not need PCI. Did angiography alone guided trials, that is the PRAMI, the culprit, and to some extent the complete overuse the PCI? But the hazard ratio was similar in all trials. So it appears that as we look at larger and larger numbers, with an FFR guided strategy, we have similar results with fewer lesions intervened. So whatever we use, the safety of the modern PCI seems to be so good that the results kind of even out in the end. Clearly, complete revascularization reduces the need for revascularization in the short and intermediate term with doubtful results on mortality. Physiology, thus, if we look at all the meta-analysis, if we base it on IFR, 1 in 3 of the treated non-culprit lesions would not have been significant at 30-day follow-up. But when we base it on FFR, 1 in 5 deferred non-culprit lesions would be significant if we follow them at 30-day follow-up. So thus physiology also has its limitations. What about imaging? Now, since Dr. KD is there, I'm going to borrow some of his slides, but this is something else which shows us that the presence of a TCFA in obstructive compared with non-obstructive non-culprit lesions actually gave a more adverse event. This is obvious and intuitive, but non-culprit lesions which are obstructive are more likely to be TCFA on statistical analysis in this particular meta-analysis that was published in Circulation. And 7.3% of patients had an obstructive non-culprit lesion containing TCFA in this study. The combined FFR negative lesions and divided them into two groups, the TCFA negative and the TCFA positive, who were given OMT. And they looked at their primary endpoints, which were essentially cardiac death, target vessel, MI, clinically driven TLR, or hospitalization due to unstable or progressive angina, versus FFR negative patients who had no TCFA, that is the group A versus group B. And there was a large 4.7% reduction, or a hazard ratio of 4.7% as far as adverse events were concerned, out to 546 days in the patients who had TCFA as compared to those who did not have any TCFA. In an interesting sub-study of what he's shown, the event rate in patients who underwent FFR along with revascularization was actually lesser than the FFR negative patients with TCFA who didn't undergo anything and had a 13.3 versus 9.7, although the two groups were not significantly comparable. Thus, addition of imaging to physiology gives us intuitive and interesting data. Obstructive plus TCFA is the maximum risk. Imaging clearly adds to risk stratification. The treatment path for non-obstructive TCFA as yet, though, is still unclear. We have imperfect prediction models, and it's possible that little more analysis of CT, biochemical markers which are going to emerge, the near-infrared spectroscopy, thermography, etc., are going to add a little more to our ability to prognosticate, although we don't know what to do about them. Although I did listen to Dr. Greg Stone with interest when he showed us some of the absorbed 2 follow-up studies in patients who underwent angioplasty with BVS for TCFA. This has probably reignited the debate on vulnerable plaque and the vulnerable patient and what we need to do about them. Now, when do we assess the non-culprit lesions? We have several opportunities: at the index event with angiography and physiology, at the initial hospitalization with angiography plus physiology plus imaging, or at a staged time when we have non-invasive available as well and functional assessment available as well. When do we intervene? Again, we have multiple opportunities: at index procedure, before discharge, staged at a time between 3 to 45 days. The ACC-AHA says that there's no randomized data at this time to support a recommendation with regard to the optimal timing of the non-culprit lesion PCI. But 4 out of the 7 trials that were looked at in the meta-analysis actually looked at this intervention prior to discharge. Complete definitely showed that whether it was done staged or whether it was done early, the benefit of complete revascularization appeared to be independent of timing in patients who had significant lesions. And there were very few events between the index procedure and non-culprit lesion revascularization. If you look at a risk-benefit analysis, this is what we should be doing for every patient. Hemodynamically unstable, we individualize, and at this time, there are too many variables to make generalizations, I feel. In a patient who's stable, definitely do the culprit lesion only. The risk for unforeseen complications which are tolerated less well in acute situations ensures, and also the out-of-hours time at which such patients usually come, prudence is probably the first most important step. If the other lesions are really critical, it's probably good to consider at the time of the primary PCI, somebody who has an RCA infarction and a 90% LAD, and it continues to have features which are unstable at presentation, we'd probably do the LAD as well, or definitely do it pre-discharge. Complicated lesions, definitely staged procedure. All others need to be individualized. What happened to our patients? This is the patient for whom, after we had finished with the RCA, we first did the FFR to the OM2. We opened the OM2. The OM2 FFR was 0.72. Thereafter, did the FFR to the circumflex OM1, which was 0.9. The LAD pre-PCI was actually 0.74. And this was confirmed on the RFR as well. So that was fixed. Post-PCI, as Dr. Ashish had shown, we always do this after the PCI. It was 0.9 in this LAD. After we finished with this RCA, we looked at the left diagnostic. This is what it was like. This is the second patient. And we did the FFR first to the circumflex. The RFR was 9.7. The FFR was 8.9. So we didn't need to touch the circumflex. The LAD didn't look so bad, but we just couldn't place the FFR wire into the LAD. After that, we thought we'd do some imaging. The OCT catheter could not cross over another wire, which we managed to place. The decision was made to do a plaque modification because it was obvious calcium. And that's what we did. The wire was exchanged, rotablation performed. Thereafter, the OCT was done post-rotablation. I'll quickly go to the images instead of showing the whole picture. We showed calcium cuts and the maximum thickness.
You can please conclude faster because all the CTO people, all the doctors are waiting. We have to see.
All right, sir. So I'll just show this is what we did post-PCI. And the FFR, we repeated again in the circumflex. In summary, factors governing immediate and staged are stability of the patient, lesion localization, likelihood of procedural success. Image-guided demonstration of high-risk class may prompt early intervention. We must do it early. My take last slide is complete revascularization is definitely beneficial. Timing of assessment is governed by the baseline risk. Timing plus by risk plus cost plus local expertise and other factors will decide what is done exactly. More data is forthcoming, and this decision making is likely to be refined and improved with imaging, invasive and otherwise. Thank you.